Hi everyone, I'm Nadine Fontaine-Palmer and I lead Mabadiliko CIC. Today I want to talk about the value of lived experience as a source of expertise in health research and our mission to democratise health research, leveraging the power of the voluntary and community sector. I'd like to begin with something personal that gets to the heart of why this matters. It's my first time sharing this story, so let's see how it goes. In 2023, I was pregnant after years of infertility and loss. I had risk factors for preeclampsia, both related to my demographic profile. I'm Black and I was 41 at the time. And I also have lifestyle risk factors. And I was prescribed aspirin preventatively, but that pregnancy ended in heartbreak. When I became pregnant again in 2024, I expected to be at even higher risk. Instead, doctors told me that this time the assessment tool, the clinical algorithm, scored me as low risk. And when I asked how they could be so sure, they explained that the tools were based on incredibly sophisticated and robust research. I asked to take aspirin anyway as a precaution, and they said no. Now here's the paradox. I believe in research. I'm the CEO of a non-profit focused on community-based research that amplifies marginalised voices. I hold a PhD funded by the Medical Research Council, and my work now includes designing hypertension screening interventions, and yet none of that reassured me. My body and my instincts were telling a different story. As a Black woman in the UK, I was acutely aware that we are more likely to die during pregnancy and childbirth than white women. And these aren't just statistics, they represent a terrifying reality that shaped how I approached my care with caution and hypervigilance. One doctor kindly offered to send me some academic papers to support the assessment, but I could not read those. Despite my professional commitment to patient advocacy and self-education, in that vulnerable state, when overwhelmed with fear about my pregnancy, I found myself unable to access the very skills I use daily in my work. I just did as I was told. The rule follower in me took over. 5 days after giving birth, I was diagnosed with preeclampsia. Now, some doctors explain that I might have developed postpartum preeclampsia, a condition that emerges after birth. However, some doctors said that based on my medical notes, it was likely that preeclampsia was missed during my pregnancy. And the truth is, I'll never know. But I do feel anger at the potential risk that both myself and my baby would have been exposed to if indeed I did have preeclampsia during pregnancy and I developed any complications. More than anything, I felt angry at myself that by relying on the research and ignoring my intuition, I may have put us in danger. And I spent much of my daughter's first month in and out of hospital, separated from her in a time that I'll never get back. I do believe in research as a force for good, but my hypervigilance as a Black woman aware of maternal health inequalities and the fear of pregnancy after loss suspended my normal researcher mind. This wasn't about knowledge or awareness, which is often the target of public health campaigns. This was about a complex interplay of professional experience, identity, and racialized trauma. And all of this reminded me that research and data are not enough, especially when it's presented without context, without space for lived experience. Sometimes your gut knows what the research might miss, and that gap between clinical confidence and personal reality is where many people live, especially those from marginalised communities who have seen systems fail them. That's why we must make space for stories and lived experience, not as a challenge to science and the methods we learn through our academic training, but as an essential part of it. By positioning communities as co-creators rather than subjects, we can expose critical gaps in clinical algorithms and create research that is both scientifically sound and culturally relevant. And this is exactly what we do at Mabadiliko CIC. We are a Black-led community interest company, and we centre lived experience in health research, service design, and system reform. We combine deep community engagement with behavioural science and social science, working with health systems and funders to try to amplify the voices of the seldom listened to and create equitable partnerships with communities, not extractive ones. Across our co-design projects, we've heard hundreds of stories that explore health behaviours and engagement in health services. And like mine, they are often featuring misdiagnoses, miscommunications, stigma, and the emotional toll of not being believed. From hypertension to diabetes to mental health, the themes they repeat. People describe feeling dismissed, racialised, blamed, or siloed into treatments and medicalised solutions that don't reflect their cultural or socio-economic contexts. We hear these things when we speak about engagement in health research also. They want to trust, but as a result of personal and sometimes group trauma, they are vigilant, hyper-vigilant. But they also tell us what helps: community-led spaces, peer validation, and being heard without judgment. These insights don't emerge from clinical trials, and they don't always emerge from qualitative studies led by formal research institutions like universities. They come from deep listening and listening by the right people, and they are essential to building responsive, effective, and culturally grounded interventions. Too often, health research treats communities as data sources, not knowledge holders. We see shallow engagement, advisory boards that hold no real power, research questions already set, and rigid systems that can't flex to cultural or contextual truths. We are involved in a thing that has already been decided. So people, especially those most at risk, get left out of shaping the very research meant to serve them. We need to flip this model and drive structural shifts in power that democratise knowledge and the relative value we put on its different forms. We have the privilege of speaking to health professionals and researchers, and many tell us with great courage that actually they find all of this really hard. Funding, of course, is a big part of the challenge, but actually many find it challenging at a deeply personal level, finding it hard to understand how a community perspective might be considered as valued as theirs. We have heard researchers challenge whether bias or racism truly exists in their institutions or work, with some displaying acute defensiveness, even in 2025. So this journey requires some cultural humility, some self-reflective honesty about why the status quo persists, and it needs leaders that are willing to go there. However, many absolutely embrace this mission and what we hope to achieve, and we strongly believe the voluntary and community sector organisations like ours can help, but not just as recruitment partners. Some of us are researchers based in the community, we are cultural translators, and we are trust holders. And when we are treated as equal partners, communities don't just influence uptake, but they can influence research design, priority setting, and outcomes. I spend my days promoting health research, and I still believe in its power. I also believe in our health service, and I'm so grateful for all of the midwives and doctors and administrative staff who helped me meet my baby. I'm also grateful to my colleagues turned friends at King's College London and King's Health Partners who took urgent calls from me seeking second opinions on my preeclampsia treatment plans. But my experience has taught me now from a very personal lens that when research is disconnected from lived reality, it stops being reassuring and it can become alienating. Democratising research isn't just about inclusion, it's about making it work for the people it's meant to serve. If we want systems that work for everyone, they must be built by everyone. And that starts with listening, really listening to the stories, the instincts, and the wisdoms communities already hold. Thank you to the organisers for inviting me to speak and letting me do this pre-recorded presentation while I navigate the challenges of being a CEO on maternity leave. It's really great to do this during that time with my 5-month-old, very beautiful, very healthy girl sleeping next to me. And thank you to you all for holding space for this story and this message. And if anyone is interested in reading more about my story or our mission, partnering with us to listen to communities, or finding out about our programs to build capacity for equitable research in both researchers and communities, then we would love to hear from you. Thank you so much.